Trends in Pharmacologic Management After Iliac Venous Stent Placement, and it is going to be presented by Daniel Veyg on behalf of his co-authors from the NYIT College of Osteopathic Medicine, in addition to the Icahn School of Medicine at Mount Sinai.
Hey everyone, my name is Daniel Veyg. I'm a third-year medical student at the New York Institute of Technology College of Osteopathic Medicine, and I'm here to present my talk on trends in pharmacologic management after iliac vein stent placement. I'd like to give a special thanks to Dr. Ting for being the primary investigator and for mentoring me through this project, as well as the rest of my co-authors. So, venous outflow obstruction has been shown in the past to play a significant role in the development of chronic venous insufficiency. The two most frequent ways that we encounter venous outflow obstruction is either due to thrombosis or due to compression. So this is going to manifest in the clinical symptoms that we observe in these patients of the development of DVT, varicosities, ulcerations, and other venous-like symptoms. The severity of symptoms that the patients will present with is actually going to determine whether we manage them surgically, medically, or conservatively. This paper is really interested in non-thrombotic causes, and the most common non-thrombotic cause of iliac vein obstruction resulting in lower limb venous-like symptoms is going to be May-Turner syndrome. Here's a nice illustration on the left demonstrating the left common iliac vein being compressed by the right common iliac artery and thus resulting in venous outflow obstruction. On the right, we see a magnetic resonance imaging showing us this exact compression. So there's currently 3 stents that are FDA approved for the placement in the iliac vein that are used. The wall stent, Venovo, and Vichy stent. There are many other stents that are currently in trial as well and are not yet approved but are being used. The objective of our study was basically to really go into the literature and see what drugs are people using to manage patients after iliac vein stent placement. So although it's not really clear which drugs are being used, and we wanted to write this up in order to kind of demonstrate the fact that many different agents are being implemented in these patients, and we wanted to understand if there's maybe a correlation between certain medications and better outcomes, and how physicians are picking these agents. So here's how we did our study. We searched the PubMed, Medline, and Embase databases for reports published in the last decade describing iliac vein stent placement. We included studies that had a minimum of 10 patients, and we excluded studies that did not mention the anticoagulation protocol after the stent was placed. We also excluded studies that had a greater than 50% post-thrombotic cohort. The reason why we did that was basically because we were concerned that if we included studies that had a large thrombotic cohort, that they would already be on anticoagulation anyway, and this would skew the results and the primary goal of our study. So here are our results. 9 studies met inclusion criteria published between 2009 and 2017. There was over 1,200 patients amongst all of these studies. A couple of interesting points that we want to make here is the fact that many different anticoagulation protocols were used in these studies, as you can see, ranging from rivaroxaban, Plavix, warfarin, to even aspirin. The duration of use was pretty standard, roughly 6 months. A huge female predominance in most of the studies, and most of the patients were roughly, presenting with the same symptoms. The CAP classification of C3 is pretty commonly seen here, and we also took into account the post-thrombotic, the cohort size of the post-thrombotic syndrome, as well as the primary patency rate at 1-year follow-up of the stent itself. Here's our results. So the average patient in our study was 55 years old. They were likely to be female. The wall stent was the most commonly used stent. And the majority of patients, as mentioned, were a CAP score of C3 or higher. Basically what we found was that warfarin was the most commonly used agent after iliac vein stent placement, and most agents, regardless of which one it was, were used for 6 months. And the primary stent patency was anywhere from 71 to 100%, with no correlation with which type of anticoagulant was being used in the post-operative phase. So although many different medications are being used and the stents are being placed with high technical success, there's really no correlation between which drug is providing better outcomes for the patient in terms of symptom relief, stent thrombosis, and generally the need for reintervention. So because there's no way to choose, it becomes, it kind of paves the way for a lot of error to potentially be made in this realm. So this underscores the importance of the fact that we need to undertake a study that will kind of illustrate how physicians and under what circumstances can physicians decide which medication is the best to use after placing these venous stents, particularly in non-thrombotic populations, in order to maximize not only uniformity across stent placement at all centers, but also to maximize patient outcomes in the long term. The only algorithm or proposed algorithm that we found was adapted from Rezavi, published in 2017. So this paper was not included in our study due to a very large post-thrombotic cohort, but there is this algorithm that they said that they used at their center, where they take into account many different factors, such as the patient's previous history of thromboembolic events, previous history of medication used, for anticoagulation or antiplatelets, and their risk for DVT in the postoperative period. So although this is a very solid model to start with, there's still a lot left that is unknown, and we'd like to call for a future study, ideally a multi-institutional study that will allow us to gather, some prospective data to determine what is the best pharmacologic agent to use after iliac vein stent placement to improve patient outcomes and to minimize the need for reintervention, particularly in those suffering from non-thrombotic venous disease due to compressive syndromes such as May-Turner's. Thank you.
Thank you for a very thought-provoking analysis. While we're waiting on questions from the audience, I thought I would kick it off. Do you have a sense of how often, you mentioned the decision-making regarding the anticoagulant. I recently was going to discharge a patient on a direct oral anticoagulant, and we changed that plan when it became apparent that due to their insurance coverage, a month's worth of it was going to cost them $700 or $800. So do you have a sense of how often, that decision's actually driven by coverage concerns like that instead of what we interpret as evidence-based choices?
So we didn't get a good chance to investigate cost analysis in our study. We weren't really able to gather that data because the studies that we did look at collected data from were just super variable in terms of how they reported these, their choice making. A lot of the studies didn't even mention why a certain medication was used over another. So, I think it's an interesting point to definitely look into in future studies, but we were not able to make that analysis.
Did any of the studies that you included in your analysis include patients who either had pulmonary embolism or were treated with thrombolysis for their initial presentation? Those types of things might also affect the time horizon for discontinuing anticoagulation or prompt us to be more aggressive on that side.
Yeah, so I believe 2 of the studies did use catheter-directed thrombolysis on their patients. So that also further kind of may complicate in terms of data extrapolation. And that's one of the reasons why we actually weren't able to perform a meta-analysis in this case, was because of how variable some of these conditions were. Yeah.
If you had one key takeaway for what the biggest gap in the literature is, you collated all this data, and as you approach this with a hypothesis, was there any element of data that was consistently missing that you and your co-authors wish was there that ought to be included in cohort series like this going forward?
Yeah, absolutely. I think that, the incidence of like stent restenosis was not uniformly reported. I think that would be a really good metric to, for all future authors to consider reporting or trying to report. Other than that, just in general, time frames were often difficult to find for how long some of these agents were being used for. And oftentimes dosing was also, believe it or not, difficult to find as well. Plavix was the only medication that was consistently reported the dose for. So those are definitely some things that would make future analyses easier.
Did you observe consistent approaches in terms of screening for restenosis versus just identifying it when it was clinically manifested?
No, there was no consistencies.
Dr. Wollauer would like to know, he congratulates you on a nice presentation and says, did you look at antiplatelet or other adjuvant medications? He recalls an elaborate algorithm published by an author named Raju that included Lovenox, Plavix, Cilostazol, and then transition to oral anticoagulation. So any comment on how often there were multiple agents or elaborate approaches like that?
Yeah, absolutely. So we also did have a couple of studies that had that did use multiple agents, and then they weren't really clear in terms of how they actually split it up between the patients. So they would just kind of list the like a laundry list of medications, but there was no clear like, oh, this many patients got this drug and this was their outcomes, right? Versus, and it was kind of just all reported as one group, even though different patients within the group use different medications. So that actually kind of ties back to the question before of like another inconsistency that we did find. In terms of an algorithm, I did not come across that paper. I did come across multiple studies by Raju. I did not come across the one with an algorithm though.
Dr. Zuko wants to know, what do you recommend for surveillance for venous stent patients? Do they routinely need to be followed for the rest of their life, or can they be safely discharged from surveillance after some time point following discontinuation of anticoagulation if they're doing well?
So I think the recommendation as of now is to monitor them for the recurrence of symptoms for at least 3 to 5 years after the stent is placed, and then if they're doing well, I think that they can be managed just based on symptom recurrence thereafter. But I do think they do need to be monitored in the initial time period after stent placement for sure, because of those complications that do happen.
Dr. Jason Kim asks, did you identify any of these series that used an initial course of enoxaparin or Lovenox before transition to another plan, and was wondering if the anti-inflammatory characteristics of Lovenox may have given an advantage using it?
Yeah, so every study that used warfarin did use Lovenox as a bridge for the first few days, which is pretty standard, we found. But we did not find any correlation between, the use of Lovenox to better patency or better outcomes. No.
Dr. Veyg, you did a great job presenting this, and maybe I'm misspeaking. You're not yet a doctor, is that correct?
No, sir. I'm a third year medical student.
So you did an amazing job with this, and I think one of the liabilities with these virtual presentations is it's harder for one of your faculty to come to the mic if we throw you a really technical or clinically oriented question like all of the ones you just got. So outstanding job fielding those questions for someone who's still a medical student, and I congratulate you on that.
Thank you.